Conversations for Health, dedicated to engaging discussions with industry experts, exploring evidence-based cutting-edge research and practical tips. Our mission is to empower you with knowledge, debunk myths, and provide you with clinical insights. This podcast is provided as an educational resource for healthcare practitioners only. This podcast represents the views and opinions of the host and their guests and does not represent the views or opinions of Designs for Health, Inc. This podcast does not constitute medical advice. The statements contained in this podcast have not been evaluated by the Food and Drug Administration. Any products mentioned are not intended to diagnose, treat, cure, or prevent any disease. Now, let's embark on a journey towards optimal well-being, one conversation at a time. Here's your host, Evelyn Lambrecht.
Welcome to Conversations for Health. I'm Evelyn Lambrecht, and today I'm joined by Dr. Keith McCormick, board-certified chiropractic physician, athlete, and author of Great Bones, Taking Control of Your Osteoporosis. Welcome to the show, Keith.
Thanks for having me on, Evelyn. Appreciate it.
I am very excited. Today we're talking about a functional and integrative approach to bone health. And I realized as I was preparing for the show and going through your book, how little I actually understand about bone health. And I feel like we don't talk about bone health the same way that we do about other body systems. And we're talking about the skeleton. It's like our foundation. So I find that very interesting. And whether you're treating patients with osteopenia or osteoporosis or looking to expand your protocols, learn more, I hope that you get a ton of clinical pearls from this episode. So before we dive into your story, Keith, what is lighting you up this week?
Well, I want to go back to what you just said about the part of the skeleton that's important. And it isn't something that we just hang our muscles and tendons on, but it is what I think of is the core of our whole existence. And I love helping people not only understand that, but ways to improve that foundation, that skeletal health that we all need so much to live our lives and enjoy actions. And I think people don't realize that the skeleton is a true organ that produces hormones. It produces, it interacts with essentially every other organ of our body. It has to do with energy regulation. It has to do with, of course, red blood cell production, hormones. It's just a vital part of our everyday physiology.
That's absolutely fascinating. I feel like by the end of this show, we'll all have a super appreciation for our skeletal health. So you've lived the osteoporosis journey personally and professionally. And so I'm curious if you can share your story and how that experience reshaped your view of bone health.
Well, I've been an athlete all my life, and and so you said I was on the Olympic team. I've been on lots of world championship teams. So I trained really hard my whole life. And when I was 45, I started having a lot of hip pain. I ended up having microfractures in my hip. And then I started having lots and lots of fractures. I fractured 12 bones in just a short time of 5 years. And so I didn't know what was going on. Anyhow, I found out I had really severe osteoporosis. I went to 5 different endocrinologists. I found out, how bad it was. And they all just wanted to put me on drugs. And I'm not against medications. I'm an integrative doctor. I really think that medications can help. But the real foundation for improving our overall health and bone health is nutrition and exercise. And I just didn't want to take their drugs and leave it at that. So I just totally immersed myself in the study of osteoporosis. At that point, I really didn't know anything much about it. I'm a chiropractor, so I knew a lot about musculoskeletal issues, but not the real nitty-gritty physiology of bone health. So I just really immersed myself. I've written 2 books since then, The Whole Body Approach to Osteoporosis and Great Bones recently last year. So I just totally immersed myself all the way so I could figure this out and not only help myself, but help other people too.
Yeah. What sport were you in?
I was on the Olympic team for a sport called modern pentathlon, so running, swimming, shooting, fencing, and riding horses. And then I switched to triathlons. I've done
Oh,
lots
wow.
lots of triathlons, including Ironman Hawaii and other Ironmans. And now I'm doing ultra distance running. I'll be doing a 100-mile race this summer in Leadville, Colorado. It's a 100-mile trail race at 10,000 feet. So I'm still training, still working hard.
Wow, that's amazing. Good luck with that. So let's take it back to basics. What is osteoporosis? And the reason I'm asking is that your definition is a little bit different than maybe like the standard definition of osteoporosis.
I think people get osteoporosis and osteoarthritis mixed up. And sometimes you tell people,
Hmm.
"Oh, I have osteoporosis," and they say, "Oh, yeah, I have back pain also." And you know, osteoarthritis is when you have joints that become uh, arthritic. They change, they get spurs on them, they degenerate and stuff. But osteoporosis is when your bones themselves, not the joints, but the bones themselves, become not only have less density, but they have poor quality. Their microarchitecture has been compromised. And the inside of bone, they're called the cancellous bone, it's made up of little struts and bars like the inside of an airplane wing. Well, if those little struts and bars are not connected well, or they're really thin and spindly, they're not going to be able to maintain the integrity of that bone very well. And that's when bones become fragile and they easily break. So I think what people don't realize is that osteoporosis is a combination. You get your bone strength from a combination of bone density and bone quality. And a bone density exam, a DEXA exam, is really just looking at density. It's not looking at the bone quality. But half of your bone strength is from quality. And that's one of the problems with bone density. But we have to look at both of those aspects. And we can look at bone quality in other ways, but a bone density machine, bone density exam is really just looking at the density itself and not the quality.
So with DEXA scans, traditionally they're recommended, is it over 50? Is that right?
Well, I
Over
wish.
50 years old?
I wish your comment was true. Unfortunately, a lot of times doctors will say, well, to a woman, "Oh, you just went through menopause, 55 or something like that. Now it's time to get a bone density." Or maybe they might say it's 60, get a bone density. Or for a male, 65 or 70 for a male. So I wish
Oh,
everybody
wow.
not just get it at age 50, but maybe even at age 40 or so. But um, oftentimes it's menopause. That's the kind of key to a PCP, a primary care physician, to say to the patient, okay, to a woman, let's get a bone density at this time. The problem with that is people are losing bone a year, 2 years, even 3 years before they actually go through menopause. And we gain our peak bone mass at maybe about age 30. And after that, we slowly start losing bone. And then women reach menopause, and then they can lose it very dramatically. Uh, a huge amount of bone loss can happen for the next 5 to 7 years after menopause. For men, it's a much slower loss, usually later in life with andropause. But women, they go through menopause and there's a huge loss. So to wait until a person reaches menopause to get a bone density isn't wise. You should get the bone density earlier so you can identify people who really need to be looked after and try to ward any more loss off. It's easier to maintain bone density than to try to gain it back. So the more we can identify people that are in trouble with a minimal loss, we identify them, then we can do things much, much better for them.
Yeah. So just to summarize, based on your experience, at what age should a man get his first scan? And for a woman, you think it should be prior to perimenopause, or should it be like age 40, for example?
I would say 45 for women, 50 for men.
Okay. Okay. That's helpful. Thank you. So I want to go back to what you said earlier about like bone density doesn't equal bone strength. And with the DEXA scan, we're looking at bone density, but we also need to be looking at bone quality. That is so important. So how do we assess bone quality?
There's one really good test called a trabecular bone score. And that is a computer analysis of the DEXA itself, of the bone density results themselves. The problem is most facilities do not have TBS capability. It's called trabecular bone score, or TBS. And in Massachusetts, there's probably only 10 or 15 places with a TBS capability with their bone density. So it's not like it's an easy thing to come by. But that measures the trabecular connectivity within the inside of the bone that I talked about earlier. When those struts and bars, those trabecula, are not connected, the person has weaker bones. And a TBS can tell us what is the percentage, essentially, of the connectivity of these trabecula. So that's probably the best way. Another way is a new, it's not that new, but it's a new technique called a REM, or an echolight. Those are done through ultrasounds, and they're not a bone density, but it's a way of assessing bone density and bone quality through ultrasound. Some people like those. I'm not completely sold on their efficacy as far as their benefit for helping me help a person improve their bone health, because they often there's often a real discrepancy between the DEXA score and the echo score, but a lot of people are using them, and I think they have some validity. It's just I'm not sure that's completely ready for prime time yet, but hopefully in the future that technology will improve and become helpful. A third way of looking at quality is to look at laboratory tests, and using bone turnover markers is a good way. You can use other labs like homocysteine and C-reactive protein. Those are lab tests that you can tell whether a person has higher inflammation, or like with a homocysteine, you're looking at the integrity of the collagen fibers within bone. The high homocysteine makes those collagen fibers a little too stiff and can increase a person's risk for fracture. So that's a quality aspect that you're looking at. The bone turnover markers, the C-telopeptide, or CTX, and the P1NP, what's called procollagen type 1 N-terminal propeptide. Those two, the CTX is osteoclastic activity, or the osteoclasts are the cells that break down bone, and the P1NP is a measure of osteoblastic activity, or how well you're forming bone. So if you look at the person's CTX and P1NP, you can get a good look into how the osteoclast and the osteoblast are relating to each other. You can see if a person's C-telopeptide is really, really high and their P1NP is not very high, then their osteoclasts are outpacing the osteoblasts, and they're going to be losing bone. And that's typically what we see, is a person has too high of osteoclastic activity, too aggressive of osteoclastic activity. And that number, the C-telopeptide number, will be over 400, maybe at 500, 600, 700, 1,000. They're losing bone rapidly. And anytime a person is losing bone rapidly, when you go back to your question of quality, rapid bone loss equals poor quality. So it's another quality indicator.
Thank you. Thank you for explaining that. And I just want to say to the listener, if you're like running to take notes, we do provide a full transcript of each show at podcast.designsforhealth.com. And I also want to give a little plug for the webinar that you did with us. It was in May of 2023. You can find that on our website in the education section. If you type in osteoporosis, there you actually have slides and it's very easy to follow because you talked about so many more markers in there. So you're making me think of talking about the bone quality when people look, or when doctors traditionally look at maybe improvements in T-score as assessed by a DEXA scan, maybe those are improving, right? Because of maybe medications or maybe some of the nutrition that they're doing, maybe their strength training. But is that enough?
That's a trick question, Evelyn. And the reason why is because so often bone density reports are wrong. And I constantly get people talking to me and they're saying, oh, I'm losing bone, or, oh, I gained a lot of bone density. And I look at the two scores, that their bone density from 2 years ago and their current bone density, and they were done completely differently, or they were done from different facilities, or at one time the first time they measured L1 through L4 accurately, and the next time they actually measured T12 to L3. So they were measuring, they didn't, instead of looking at apples and apples, they looked at apples and oranges. So I would say 60% of the time,
Interesting.
I find bone density reports wrong. And so I always look at the bone density printout, the actual printout from the bone density machine, and where there's little thumbnail pictures on the printout. And those thumbnail pictures are vital for really being able to assess, analyze whether the bone density was done properly. There's many places in the flow of how they get bone densities to where things can go wrong. The technician not only has to align the person properly on the table, but they also have to then outline the same vertebra. They have to outline the hips in a certain way. They have to then do the actual bone density properly. And then the radiologist actually has to read the printout properly. So there's lots of places in this whole process where things can go wrong. And unfortunately, they do go wrong. So a lot of times determining whether a person really did gain bone density or lost bone density is not as easy as you would think.
That's really interesting. It actually makes me think of how we could possibly use AI in this context to kind of maybe like standardize some of it.
Yes. AI is going to revolutionize things. And even in speaking of which, even right now, that's improving. AI is improving things for identifying fractures. So right now, I find fractures in x-rays all the time that were not pointed out by the radiologist. And the reason why is because most radiologists need to see at least a 25%, 20 to 25% loss of bone height in that vertebra to call it a fracture. AI is going to change that whole thing. And we're going to be able to identify many more people with fractures than we are now. So yes, AI is going to help not only in x-rays, but in bone density.
That's really cool. What made me think of it is there's a lab called, or a company called Clearly Health, Cleerly. I think it's come up on the show before. And they're looking at atherosclerosis using AI, and just being able to be more precise and standardized. So that's really cool that that's coming. Of course, it's already in the works, but that'll help all of us. So I want to talk about nutrients. I also want to talk about medications. Actually, let's talk about medications first. You're not against using medications to treat osteoporosis. I do have a question. When are you a fan of using it for osteopenia, or do you think it should be used just for osteoporosis? And then talk to me about some of the risks and benefits of these drugs. And I know there are many classes of drugs for these. I know that's a big question.
You're always trying to trick me with your questions because that's another very tricky question. The question of, do you give a medication in osteopenia or just osteoporosis? Looking at that point blank, I would say I would never do a drug for somebody with osteopenia. But that's not completely true because so many women and men, as they get older, they have so much degenerative joint disease in their spine, so much arthritis in their spine, that their spine looks like it's osteopenic when in fact they're fracturing and they have osteoporosis, but it looks like it's osteopenia on the bone density, only because they have fractures already and because they have degenerative joint disease, osteoarthritis, and that makes the skeleton look more dense than it really is. So in those people, if they're fracturing, they need to go on a medication, even though it's osteopenia, because it's not really osteopenia. It's just osteopenia.
Interesting.
As far as looking at the DEXA itself, the score of the DEXA. But if we get rid of osteoarthritis and we just look at the spine, a non-arthritic spine, if a person has osteopenia, I don't think I would ever put them on a medication. The thing to do with them is nutrition, exercise, diet, the way we live our life. That's the most important. And even when people have osteoporosis, lots of times medications are not necessary. We have to look at everything. We look at those bone turnover markers. If we can get their bone turnover markers to be appropriate, in other words, the C-telopeptide at 350 or 300, so they're not losing bone, but a very robust P1NP of 40, 50, something like that, which is saying their osteoblasts are doing a really good job and their osteoclasts are not ramped up and they're not breaking down too much bone, then we're going to stabilize that person. And with exercise, we're going to make their bone quality better. So no, there's many times, even with a person who comes to me with osteoporosis, that they don't have to do medication. But when a person starts fracturing, then we really have to seriously think about an anabolic drug.
And something that you talk about in your book is that patients are placed on these drugs for, I don't know if it's like forever, but what I got from going through your book is that maybe patients should be on this for like 2 to 3 years and be managed concurrently, right, with diet, exercise, nutritional supplements, perhaps, and then, continuing with that. Can you talk more about that?
The answer to osteoporosis is not medication. The answer to osteoporosis is diet and nutrition and, the supplements and exercise. That's the answer. On the short term, though, we have to get people out of trouble. We have to get people out of danger of fracturing. And that's where the medications comes in. It's like an emergency medicine. Okay. They're really, really low in bone density. Their TBS is really low. They're at high fracture risk, or they've already fractured. Yes, they need to go on a medication for 2 or 3 years at least, maybe more, but typically not. I would say 98% of my people, if they're put on if I suggest a medication, they're only on it for 2 or 3 years, and then they're not on it again, or if they are, very intermittently. But most of the time, it's during that first part where they're really in trouble, where they're really at danger of fracturing. That's when you use the medication to get them out of that danger area. And all during that time, though, we're doing other things to improve their whole health. And that is nutrition, exercise, diet and stuff. That's the real foundation of improving them. But that said, many times we have to do the osteoporosis specific medications. And there's 2 kinds of medications. There's the anti-resorptive medications. That's the bisphosphonates and Prolia. So there's essentially five anti-resorptives. And then there's 3 anabolics. There's a few other other things in there, but the three anabolics are Forteo, Timlose, and Venity. And when a person is fracturing or their bone density is very, very low, then you really should go to an anabolic drug. If it's not so low, or they're not losing bone terribly rapidly or whatever, then an anti-resorptive might be the way to go.
Thank you. That's very helpful. So let's talk about some of those other factors in the foundational treatment, I guess, for osteoporosis. So let's talk about diet first. What are your top recommendations when it comes to like the best diet for bone health?
I always think of protein first because bone is protein. And I know there's a lot of people out there on the protein wagon right now that are I think they're recommending a little too much protein, 100, 110 grams, 120 grams, something like that. I think for the average woman of 25 to 35 pounds, 125 to 135 pounds, maybe 70 grams or so would be really good, 75 maybe. But I don't think we have to go up to 100. But the protein is really important. And it's hard to even get 70, 75 grams of protein. But that's why it's great to have, whey protein, pea protein, hemp protein products, amino acid products. Those are really, really helpful for, I'd say, to me, the protein is number one. I know everybody talks about calcium, but I always talk about protein sooner. But obviously, calcium, magnesium, trace minerals are important. I never recommend calcium carbonate. I always recommend like a calcium malate chelate or bisglycinate or citrate. Those are good calciums. Magnesium, 400 milligrams magnesium, of magnesium malate chelate, bisglycinate, citrate. A combination of calcium, magnesium is important. I think it's hard to get enough calcium in our diet. Especially a lot of people don't eat dairy, and I think it's really difficult to get that calcium. Of course, vitamin D, and I usually suggest 40 to 60 on nanograms per ml on the vitamin D, and I don't think you have to go up to 80, 90, 100. I think that's overdoing it and can actually be detrimental to your bone health if you go too high on your vitamin D. So just 40 to 60. And then vitamin K is so important. And I think if people understand the why, then they'll say, okay, yeah, I'm going to take the K because it's really, really important. So your osteoblasts produce this protein called osteocalcin. And osteocalcin, you need to have osteocalcin to essentially form that bone crystal. But that osteocalcin has to be activated. You have to activate it with vitamin K. And once it's activated or carboxylated, now we can form bone crystals. So you really need that K there all the time. So the K, the D, calcium, magnesium, trace minerals, protein, I'd say those are the most important. And if you have high C-telopeptide, high bone turnover, those osteoclasts are really, really breaking down a lot of bone. The way to reduce that is antioxidants, because the osteoclasts are kind of a form of a white blood cell. Their activity level is ramped up when we have oxidative stress. One of the products I'm not sure if I can mention this, but for a product that you have at Designs for Health that I really, really like is there's resveratrol synergy, and that has resveratrol and quercetin in it. And that's really good for bringing down that oxidative stress. So I use that all the time. But antioxidants like alpha lipoic acid, N-acetylcysteine, berberine, the resveratrol, the quercetin, they all really help calm down those osteoclasts because they're reducing oxidative stress.
Okay. Yeah. So it's resveratrol supreme. And usually we don't talk about product names, but since you mentioned it,
Right.
but that's the one that you're talking about. So I had asked you about diet and you also went into supplements, but I want to go back to the diet for a little bit. I mean, it seems like just, I just interviewed Deanna Minnick too. We talked about the rainbow of food and eating that. That seems important, obviously, when it comes to antioxidants, with getting magnesium, from green leafy vegetables. The protein is important. Any other like power foods for bone health? I mean, do you believe that drinking bone broth has benefits for bone health?
I I suggest people drink bone broth, but also the collagen. I think
Yeah.
Collagen helps not because of the amino acids, but because of the polypeptide chains within amino acids. And the peptide chains can
Hmm.
directly stimulate those osteoblasts to build up bone. And if you take a person and they have a low P1NP, let's say a person has a 35 for a P1NP, you give them collagen and bone broth, that P1NP will go up 5 points. And I mean, it's not just a
Oh, wow.
guess. You'll see it go up. And that's cool, So yeah, it helps improve that osteoblastic response to what you're doing.
That's great. I'm a big fan of collagen. I want to talk about maybe some other nutrients that we don't typically think of. I know you're a fan of delta and gamma tocotrienols. Can you share more about how those can help bone health and maybe some dosing that you use in your patients?
Well, I'm going to get off on a little tangent because that is such an important question for
Okay.
so many reasons. Well, most people now are starting to become familiar with the endothelial glycocalyx in the inside part of our blood vessels. And that, like, if people want to look up one cool thing on the internet, just punch in endothelial glycocalyx and then pictures. It's just beautiful when you can look at that glycocalyx and see what is inside these vessels. And the reason why that's important is so the glycocalyx are these little glucose type molecules that stick into the small capillaries of our blood vessels, and they register things like how the blood flow is going through your capillaries and the different chemicals within it. But they're registering these things and then sending signals to the rest of your body to take action, to normalize things. The problem is when people get cardiovascular disease, and cardiovascular disease and osteoporosis go hand in hand. And the reason why is because when you have cardiovascular disease, that glycocalyx is typically not working as well. Now we have decreased perfusion of blood into our bones. We need blood perfusion into our bones to bring nutrients, but also that glycocalyx is not just in the capillaries of our bones, into the vessels of our body, but between so there's three types of bone cells: osteoblasts that form bone, osteoclasts that tear down bone, and osteocytes that they're the overall regulators of the osteoclastic activity and the whole bone remodeling system. Well, the osteocytes actually have little tubes that connect between them. And similar to capillaries, those little tubes and how osteocytes talk to each other have a glycocalyx within that little tube. And when that glycocalyx is not functioning properly, your osteocytes can't talk to each other properly. So the whole bone remodeling system gets out of whack. And that's why when you're talking about the tocotrienols, why that's so important. And so a tocotrienol, for people who don't know, for vitamin E, you have tocopherols and tocotrienols. And the reason why I use that product is because it helps the anато-E helps a person lower their LDLs, their low density lipoprotein, the cholesterol. And I talk about this in my book about PPAR gamma. And PPAR gamma is this chemical that your body produces that directly stimulates your osteoclast to break down bone. So when a person has high LDL cholesterol, that stimulates their production of PPAR gamma, and PPAR gamma stimulates osteoclastic activity. So it behooves us to lower our LDLs, and the tocotrienols help to do that. There's lots of other things. Red yeast rice helps lower cholesterol, which is really important. There's different nitric oxide boosters that are really important to improve that glycocalyx. You know, we're getting a little bit on a tangent, but the reason why is because, like I said earlier, cardiovascular disease and osteoporosis go hand in hand. So we want to make sure that person's those people's blood vessels are functioning well. And if they do, if their blood vessels are functioning well, they're going to get more blood perfusion. They're going to get better osteoblastic activity and a more balanced bone remodeling, more balanced interaction between the osteoclast and the osteoblast and the osteocytes.
This is super interesting. I actually had a question for you about the endothelial glycocalyx and the connection to bone health, because you mentioned it in your webinar. And we've talked about the endothelial glycocalyx quite a bit on the podcast. We did episodes last year with Dr. Mark Houston and Dr. Christine Burke and Dr. Michael Twyman, but it was really just about cardiovascular health. Mm-hmm. And I had not been thinking of that connection. And we know that we have certain nutrients that really help to restore the endothelial glycocalyx. So that is super interesting. I'm so glad that you brought that up. I'm just fascinated by that.
So one more thing about vitamin K is that you're talking about the connection here between osteoporosis and cardiovascular disease. Well, vitamin K is part of that whole game, in that there's this chemical in our body called NF-kappa B. So anytime you have an inflammatory reaction within a cell, whatever cell that is, we have this stuff called NF-kappa B. And as that rises with oxidative stress, we have more NF-kappa B, more inflammation, more production of pro-inflammatory cytokines. Vitamin K can help reduce that. So anytime you have a reduction in vitamin K, we're not only going to have less osteocalcin, but also this what's called a receptor for activator nuclear factor kappa B, this NF-kappa B, and then that stimulates the osteoclast, but it's also unhealthy for just as far as bringing up inflammation throughout the whole body. And when we have inflammation, we have more risk for cardiovascular disease and for osteoporosis. So.
Yeah, it really all boils down to inflammation, right?
Yes.
I have a follow-up question on that. So what about patients who are on blood thinners? What are your thoughts on them with vitamin K? Do you still use it?
I think that's a really an important question. If a person's on something like warfarin, then yes, I would definitely not push high levels of K on that person.
Mm-hmm.
But if they're not, if they're not on warfarin, then if they're on another type of blood thinner, then they need to be talking to their doctor about the K involved. But yes, I would not do the K with that. So.
Okay. So with all of the interventions that you are doing with your patients, how often do you recommend retesting with a DEXA scan? And also, how often do you retest some of the other lab markers? And I mean, it would be confusing, I think, on a podcast where you're listening and you can't see it, to list all of the labs that you go through in your book or in your webinar. So I recommend using those as a reference. But yeah, how often are you reassessing those?
For bone density, that it all depends on what we're doing. Typically, bone densities are done every 2 years. That's what insurance will pay for. But if we start a person on Evenity, romosomazab, it's what's called a sclerostin antibody. It's one of the anabolic drugs. Then I would do a bone density after only 1 year. And probably if they did Forte or Tymlos, the other two anabolics, I would still do it after 1 year. But typically speaking, I would only do a bone density every 2 years. If a person was put on prednisone, they had some inflammatory disorder and they were put on high doses of prednisone, I would definitely get a bone density more often on that. I would get them every year on that. So there's different reasons why you want to do a bone density sooner than 2 years, but those are some of the reasons. As far as the blood tests, and that's what's so cool about blood tests, is we can tell when we're making a major improvement, or whether we're failing miserably in helping this person by getting bone turnover markers every 3, 4, or 5 months. So if we start a person has a C-telopeptide of 600, and we put them on a program of a nutrition, diet, exercise, supplements, things like that, and we get them down to 400 or so on the C-telopeptide, we know that what we're doing is working. We don't have to wait for 2 years. We know after 3, 4, 5 months. If it stays at 600, we know we're failing. We need to do something else. So that's the great thing about getting baseline bone turnover markers, baseline other labs too, and then I call them therapeutic targets in my book. So we find something that's wrong: high CTX, low P1NP, high homocysteine, high C-reactive protein, high loss of calcium in the 24-hour urine calcium, any of those things. If we find those things amiss, we focus on that. We try to improve those indices, and we know right away within a couple months whether we're winning the game or not. We don't wait for 2 years.
Yeah, that's great. I think we'd be remiss if we didn't address the exercise component. So we know that strength training is very important for bone health. Do you also recommend like power type exercises? And then I'm curious, so you as an athlete who did these endurance sports and are still doing endurance sports, do you think that that might perpetuate like poorer bone health versus doing more of the strength training?
Definitely. Yes, I think it does. I think
Okay.
when a person goes crazy and starts doing training for 100-mile races, then I think it is a danger to reduce your bone density. But all during that time, that I'm training hard, I am really eating well, or trying to. I'm getting the protein that I need. I'm also doing weightlifting, like deadlifts and squats and things like that. So I'm doing a lot of weightlifting. And yes, I think if a person, so exercise is incredibly important, and walking doesn't cut it. If you're going to spend your time doing certain things,
Right.
please use a trainer, a physical therapist to help you out, because it's easy to get hurt doing weightlifting. And so you really need to have somebody watching you and making sure you're doing these exercises with the proper technique. But yes, that will improve your bone quality. You're not going to see probably an improvement in bone density, but there will be an improvement in bone quality when you do weightlifting exercises. But it has to be done properly, because it's easy to get hurt.
Yeah. And thankfully, we are as a society talking more about the importance of weightlifting, especially in women. I, see that everywhere right now. Something else that I wanted to talk about specifically for women. So we know that estrogen is really important. I feel like we haven't really touched on that enough yet. So with estrogen going down, as we go into menopause, we know that it's recommended now, I believe, to start BHRT, if appropriate for the person under the physician guidance, to replace some of that estrogen, right? But I'm curious, just like, what are your thoughts on that? Is there a way that with taking BHRT, we really can preserve our bone health so we don't get osteoporosis, maybe till we're like 90 or never?
I'm a very big proponent of HRT, of hormone replacement therapy, and I think it has a huge place within bone health. The problem is many people are still stuck in the research from 2001 in the Women's Health Initiative study, where they used oral estrogen and a large dose of 0.625. And I think now we're starting to realize that it's safe to use transdermal, whether it's a gel or cream or patch. I happen to like patches more. I think there's a lot of differences in women's skin as far as their ability to absorb estrogen, estradiol. But I think it has a huge place in helping lower C-peptide. Estrogen helps other things besides bone, helps your brain and other organs too. But as far as I'm concerned, or what I do is, I'm focusing on the skeleton. And estradiol is an immune system modulator. It calms down the immune system. So when you calm your immune system down, you're going to calm down those osteoclasts, because they're kind of related to the white blood cell. They listen to all the chemicals that are happening in your body, all the cytokines that are from the immune system. And when they hear when there's oxidative stress, when there's free radicals, when we have interleukin 1, interleukin 6, tumor necrosis factor, all these cytokines that are causing inflammatory reactions in our body, they get excited and they do one thing, and that's break down bone. Well, estrogen helps rein them back in. And so, yes, when a woman goes through menopause, to go on a patch, a low dose, like 0.025, 0.0375, and some progesterone, I think helps calm down those osteoclasts dramatically, and can not only preserve, but I see it improve bone density in some situations. I think, if a woman's going to go, approach it through HRT, I don't think she should think of maybe improving her bone density, but for sure cutting the losses. And and the reason why I say that is because if a person is fracturing and they have a bone density of negative 4.2, the HRT is not enough. They're going to still have to do an anabolic drug.
Mm-hmm.
They might have to do them at the same time, the anabolic drug and the estrogen at the same time. That's okay. But you wouldn't want to just rely on the HRT in that situation. But the HRT is a huge benefit, can be a huge benefit to somebody for stopping that bone loss and allowing them to and the good thing is it doesn't just stop that bone loss, but if a person is now exercising at the same time, wow, they get a lot more benefit. Because remember, if a person takes a bisphosphonate drug, you're essentially killing off, or at least making, those osteoclasts sick. And now those osteoclasts can't signal the osteoblasts to form bone. So now all of bone remodeling goes down, and now exercising doesn't help as much. But if they're on HRT, it calms down their osteoclasts. The osteoblasts can still do their job in making bone, and now the exercise in combination can do a way better job.
Super interesting. Thank you for sharing that and sharing those little nuances of this. I have one more question before our wrap-up questions, which is around other nutrients that maybe people don't think about when it comes to bone health. And I know that you use GG in your practice as well, and it's a compound that we've talked about on the show, geranyl. Can you talk a little bit about that and its relation to bone health?
Well, it helps improve their ability to produce K2-MK4. So the combination of taking the tocotrienols and the GG really helps a lot, because we're not only lowering the LDLs, or to some extent, but we're also now promoting that production, that natural production of in our body of the K2-MK4. So it really, it's a great combination to kind of do. So.
Great. Thank you. Okay. I just have 3 questions that we ask every guest at the end. The first one is just for yourself. What are your 3 favorite nutrients to take, or supplements?
I guess collagen, alpha lipoic acid. Well, that's tough. Can I say 3 things really quick? Calcium, magnesium, and N-acetylcysteine. All those would be important.
Sure. Great. And then what are your favorite health practices that keep you resilient and balanced, especially when you're preparing for a 100-mile race?
I love to be out in the sun. I love to be out in the woods, and I love helping people. I was talking to this woman this morning, and she was unbelievably delightful. I think she was 78 or so. She was from Georgia. I loved her accent. And I'm thinking, God, this is so fun what I do. It's like just talking to her was so, you feel like you're in their living room and you're just sitting there on the couch talking. And so I think that's what keeps me going. So
I love that. That's amazing. And what is something that you've changed your mind about through all of your years in practice?
I wish, and I probably shouldn't say this, but I wish I could say I've changed my mind about doctors and how they treat nutrition. And they're coming around to it a little bit, but I wish that the traditional medical doctor would have a little bit more respect for what nutrition can do for us. And it's changing, but we got a long way to go.
Yeah. Well, thankfully, the ones who listen to this podcast are very much aware of the power of nutrition. But it's true. I do see the tide shifting.
Well, the reason why I say that is because I have a very dear friend, and he's a medical doctor, and we went on a bicycle ride, and I kept saying to him how excited I was that I can take nutrition and change people's C-peptide. And he goes, no, you can't. And I said, yeah, I do it all the time. He goes, no, you can't. And even though he's a friend of mine, even though he likes me and respects me, he could not get it in his head that I can change people's C-peptide, bring the CTX down by nutrition. He wouldn't accept it.
Oh, well, there is research on that. They always say, show me the research, but you can usually find it if you look for it. So, well, Keith, thank you so much. This has been a delightful conversation. That's actually the word I would use. I'm so grateful to you for sharing your knowledge, not just on this podcast, but in your book, which is very comprehensive. And again, I do recommend checking that out. Great Bones, and also the webinar that we did with you last year. And just thank you so much.
You're very welcome. Thanks for an awful lot for inviting me on, Evelyn. Appreciate it. It was fun.
Absolutely. And thank you for tuning into Conversations for Health today. Check out the show notes for resources from this episode. Please share it with your colleagues, follow, rate, and give us a 5-star review or leave a review wherever you listen. And thank you for designing a well world with us.
This is Conversations for Health with Evelyn Lambrecht, dedicated to engaging discussions with industry experts, exploring evidence-based, cutting-edge research, and practical tips.